Now, Executive Suite with WPRI.com reporter Ted Nisi.
Welcome to Executive Suite. I'm Ted Nisi, and we're talking today about one of our favorite topics on this show, the business of healthcare, a major industry in Rhode Island and one that's really under the microscope these days for a variety of reasons and seeing a lot of changes. And joining us to talk about it today is one of the senior leaders in Rhode Island's healthcare sector, the president and CEO of Care New England. They own Women and Infants and a host of other hospitals, Dennis Keefe. Dennis, thanks for joining me.
Thank you.
And I should add, you're also chairman of the Hospital Association of Rhode Island.
That's correct.
And you're co-chair of Gina Raimondo's Medicaid Working Group.
Right, that's right.
A lot of hats these days.
A lot of hats. I have to figure out which hat I'm wearing at any particular point, so it's good.
It's too many for us to quote at the end.
Right.
So obviously, unlike some companies we have on this show, people understand what you do at Care New England as a hospital. But I was wondering if you could give viewers a sense of the scope of the enterprise, how many procedures you do, how many employees you have, that kind of thing.
Right, so Care New England was formed in 1996, and at that time it was Butler Hospital, Women and Infants Hospital, and Kent Memorial Hospital. Since then, and since my arrival, we've added Memorial Hospital of Rhode Island. Most recently, we've added the Providence Center, a large, second largest behavioral health organization in Rhode Island. And we have a number of strategic partnerships as well that are related to Care New England, like Rhode Island Primary Care, PC. We have a strategic partnership with CVS. So we have a lot of things going on there, and we've grown. We are now at over 8,000 employees. I think when I arrived in 2011, we were just over 5,000. We're over $1 billion in revenue, and again, when I arrived, we were, under 800 million. So we've seen a lot of growth. We've seen a lot of expansion. We've added a number of organizations. We've developed a number of strategic partnerships, and it's all been aimed at a particular goal, in terms of what we're trying to do here in Rhode Island. But that's the scope of it. All of our hospitals are quite busy. The census has been quite high at all of our campuses, or we call them operating units. Right through the winter. The winter was very challenging, as I'm sure you can appreciate. But very robust organization, and we've gone through a lot of change and a lot of expansion.
And you mentioned coming down in 2011. You were in Cambridge before that for years.
Right.
What would you say, what's been your top priority as CEO?
Well, being in Massachusetts, I was there from 2006 to 2011, and that was really the birth of what people call now Obamacare. We called Romney Care, approved by the Bush administration. A lot of people don't realize that. But I really lived through the good, the bad, and the ugly of healthcare reform and payment reform in Massachusetts. So I really saw what worked, what didn't work. So I actually came here to Rhode Island, was recruited to Rhode Island, and I thought, with a blueprint for, what do we need to do over the next several years to directionally be prepared for where the healthcare industry is going. And it actually has been going for a number of years now. So that was the big thing. And if I was to sort it all down, and this gets kind of wonky for non-healthcare people, it's really to be certainly a regional, if not a national, expert in the area of population health management. So it's moving away from where we've been in what's called the traditional fee-for-service system.
And that's just paying for each time you do a procedure. I checked your eye, I fixed your leg.
The more we do, the more we get. The more times you're in the ER, the more we get paid. The more times we admit you, the more we get paid. The more procedures we do on you, the more we get paid. And historically, it hasn't really related to whether there's value to doing all of that work. And even historically, it wasn't related to are the outcomes good or better based on all the things that we've been doing. So across the country, people are moving away from the so-called fee-for-service system, really doing work just to achieve volume and revenue growth, really towards more getting value for the investments we make in healthcare, but including that value is better outcomes, always looking at the outcomes of whatever we do, and really changing payment systems that I think in the past have created perverse incentives actually towards developing the kind of healthcare system in the country that I think the general public
and I know that's going to come up a lot more as we talk about the Medicaid stuff you've been working on. I want to ask you a few more questions about Care New England specifically. You took over, you mentioned Memorial Hospital in Pawtucket in 2013. Memorial had some debt. Memorial had deficits projected. How is Memorial's financial health at this point?
Right. So Ted, I get that question a lot. I do this thing called At the Table, where I meet with a group of employees, randomly selected employees at each operating unit. Every month I try to get out and meet with employees directly. No managers in the room. And I get that question a lot. Why did we do Memorial? And people have even said to me, looked me in the eye and said, did you know they were losing money when you kind of took them on? They are doing better. When we took them over, they had lost $15 million the last fiscal year that we took them over. We've knocked that down to less than half of that number. But really, Memorial, beyond being a full-service medical surgical hospital with a lot of potential in that market, we really want to do a better job of serving that market, the Pawtucket Central Falls market. But as a strategic asset, when I'm thinking about the future of healthcare, and you get into this area of population health management, you hear me come back to that frequently, and how do we fix healthcare going forward? It's really very strongly based in excellent primary care. Primary care needs to drive the system. Primary care physicians need to be the drivers to health and really, improving the health of the population. And Memorial has real strengths in that area. They're a very strong primary care oriented organization. They have an internal medicine residency program. They have a family medicine residency program, the only Brown family medicine residency program in the state. So when we're looking at population health management and transforming the future healthcare delivery in Rhode Island, primary care is critical to that future. So in terms of being a strategic asset, Memorial really very, very important to that future. Our own source of trained physicians who we can retain to work across Care New England as we deploy primary care.
Sounds like you've had to give this speech before on the Memorial decision. Now, even with Memorial in place, your margins are very tight, less than 1% in the last fiscal year, and that's a Rhode Island-wide thing. Why are margins so low, operating margins for our hospitals here?
Well, multifold, not simple, but I'll give you a few indicators. One is, and we're going to probably talk about reinventing Medicaid. Medicaid utilization is high. 25% of the population is covered by Medicaid. The challenges with the economy, joblessness, driving greater Medicaid use. So Medicaid utilization is high. It's higher than in a lot of other states, quite frankly. I'm talking about the people being covered. I'm not even talking about the expense, which is about 30% of the state budget. Medicaid does not pay the full cost of care we provide. The other end of the spectrum is Medicare. So the population, again, in Rhode Island, in terms of the elderly, is higher as well.
Particularly old elderly, right?
Old
85
elderly,
plus.
Right. So again, Medicare doesn't cover the full cost of care. So you have, high Medicare, high Medicaid. So that's not a formula for success in terms of hospital revenues. And then the one I think that has really kind of flown under the radar here over the past 3 or 4 years is the Office of the Insurance Commissioner Contracting Standards. You're probably familiar with them, where it actually limits the amount of rates that we can increase within our insurance contracts, whether it's Blue Cross, United, or Neighborhood Health Plan. We can only go up so much per year. And we've been tracking along, believe it or not, over the last several years at the Consumer Price Index. I'm not talking about the medical Consumer Price Index. I'm talking about the straight,
which is always lower
CPI.
than the cost of medicine going up.
Right. So it's been, really only 2 or 3%. So it used to be historically you could get underpaid by Medicaid, you could get underpaid by Medicare, and you were able to really transfer a little bit of that to the commercial insurers. That's gone. So in those 3 areas alone, you can see why margins are really being challenged.
Interesting. All right, well, we're going to talk more about your plans on what to do about that, as well as the Medicaid task force you served on. Stick with us. We're talking with Care New England President and CEO Dennis Keefe. We'll be back on Executive Suite. Welcome back to Executive Suite. I'm Ted Nisi. We're talking today about the business of healthcare with one of the top leaders in the industry in Rhode Island, Dennis Keefe. He's the president and CEO of Care New England, which owns Women and Infants, Kent, a whole host of things he ticked off at the beginning. So you want to go back and watch the full show online if you missed the list. It gets longer and longer. I want to ask you, Dennis, we were talking before about operating margins. Another thing I hear about sometimes with the hospitals in Rhode Island is that, you know, you're not in a vacuum and there's competition from Boston. Partners Healthcare, the other huge things up there, they're trying to lure Rhode Islanders up there for profitable procedures. Are you seeing that at Care New England? Are you impacted by that?
Well, it's interesting, and again, Ted, I get this question a lot because we actually have a strategic partnership with Partners and Brigham and Women's specifically, where they actually provide a lot of cardiology services in Warwick in the Kent service area. So,
in bed with the enemy, then.
In bed with the enemy. So people are always worried about we're going to invite partners in and they're going to take over the state, and it's going to be like the banking industry. We're going to lose the healthcare industry. I hear that all the time. People are concerned about Harvard Medical School coming in, and they're going to take over Brown, and so there are those concerns, and I take them very seriously. And so I did not come to Rhode Island to bring Boston to Rhode Island. I came here to bring the best of Boston actually into Rhode Island. And that's really, to me, the win-win, where we actually have a lot of Brigham-based cardiologists at Kent really doing superb work at Kent to treat the local population with state-of-the-art cardiology care. So we just got approved, for instance, for angioplasty, you know, heart catheterization procedures to clear clots. So a lot of people, to me, even though there's competition in the area, if they don't like the local health care, they vote with their feet. So, you know, people are going to Boston. You know, it's not like we can say, stay here. If they feel there's better care in Boston, they go to Boston. So if you can bring that high quality care here, people stay. And we have the information now to demonstrate that people are staying. And they are getting their care locally based on this Brigham affiliation. It's our cardiology group at Kent and the Brigham Cardiology Group that are collaborating in keeping that care local. And then the other thing is, if someone actually needs to go to Boston, we've sent people to Boston for transplants even, or very sophisticated procedures that aren't even done in Rhode Island. That care goes to Boston, it's coordinated. And then when the patient is done receiving their care, they come right back to the community, right back to that primary care physician I was talking to you about. So it's bringing the best of the care locally, keeping care local, which is what I strongly support. But if the care, you know, is not offered locally, or the patient's choice is not to have the care locally, we do send them to Boston. It's not a large number at all. But even then, the care is coordinated, returns to the community afterwards.
You know, you bring up the question of size. You know, we've seen so many mergers in the hospital industry. And last fall, Governor Keefe, before he left office, said to Tim White and I on our other show, Newsmakers, he said his regret was that he couldn't get you guys to merge with Lifespan after the original merger effort didn't come together. Is that on the table? Is that something you still consider, or you see Care New England as staying independent?
Well, it's a great question. I've heard Governor Chasey talk about that, and I worked with him directly.
He probably said it to you.
I would just say that it wasn't even as remotely close as he described. So I think we were talking. I mean, there was conversation going back and forth. But I think at the time, I think Tim Babineau would verify this, we agreed that after literally 3 failed merger attempts in a row, you know, Lifespan 1, then a failed merger attempt with Care Group, then Lifespan 2, no one had an appetite to go down that road again. Plus the other failing is maybe the time had passed, because a number of years ago, the Federal Trade Commission might have allowed this kind of merger to go through. I think it's a real question nowadays, because they have been denying a lot of mergers across the country. They're very worried about, you know, anti-competitive effects. But the direct answer to your question is never say never. I'm not doing my job unless I'm out there talking to everyone. And this issue that you're bringing up of scale, I call it geographic coverage and scale, is going to continue to be very, very important for the future of healthcare. It's a kind of consolidation that's driven by Obamacare. It's sort of like a little bit frustrating that Obamacare is driving consolidation, but the FTC is saying, don't do it, so it kind of puts us in a little bit of a quandary. But directionally, I really feel that regional healthcare is going to be part of our future. And everyone's talking to everyone. And I know we're talking to people because you had heard some things in the marketplace. But everyone's talking to everyone.
Interesting.
And I'm not doing my job if I'm not out there talking to everyone.
Yeah. Direct answers. We love that on Executive Suite. All right. So you really don't want to go away because you don't know what Dennis Keefe's going to say. The President and CEO of Care New England. It's great. Well, stick with us. We're going to talk about his work on Governor Raimondo's Reinventing Medicaid Task Force when we come back. Stick with us on Executive Suite. Welcome back to Executive Suite. I'm Ted Nisi, and we're having a candid conversation today about the business of healthcare in Rhode Island with one of the top executives in the industry, Dennis Keefe. Since 2011, he's been the president and CEO of Care New England, Women and Infants, obviously the flagship, but they're in a lot of other stuff, and he wears a number of hats. One of those hats has gotten you a lot of attention lately, co-chair of Governor Raimondo's Reinventing Medicaid Working Group. Now, to remind everyone, Medicaid, huge part of the state budget, more than $2 billion all in. The governor wanted your group to come up with about $90 million in state savings. You've put forward these cuts. Are you concerned about the impact those cuts will have?
Sure. So a couple of things, Ted. Number one, I applaud the new governor for taking healthcare very, very seriously in terms of her agenda going forward. My experience is when governors and the Assembly work together to really improve healthcare, and it's on everyone's radar, you really do get great outcomes. So I think her stepping into the space is huge. And then I think I would broaden the discussion to beyond Medicaid. I mean, the growth in healthcare expense is unsustainable. We have to have a way of bending that cost curve so that it becomes less expensive, whether it's Medicaid or commercial insurance or Medicare, because it's unsustainable for businesses. Businesses can't grow, they can't expand. It becomes more and more of their budget. It's up to, 18% of the GNP across the country. So healthcare expenses are a huge challenge. It's a huge challenge across the board. Medicaid certainly is part of that. So I was honored to be asked by Governor Raimondo to co-chair this task force.
Not an easy job, though, coming up, cutting your own budget.
Right. No, I know. I get a lot of congratulations. People are kind of winking when they're congratulating that I'm doing this. But we were given a charge, and I take that very seriously. If I'm asked to do a job, I try to do the best job possible. But at the same time, looking at the challenge is, how do we, do what the governor's asking us to do, but in a way that really does advance healthcare reform. So the Hospital Association of Rhode Island proposals were really aimed at that. One part of it was to, again, we did this last year, increase the provider tax because that brings in more federal dollars. The state budget had eliminated that as one of the cost-saving measures, and then you lose the federal match. So we stepped up again, said we'll increase the provider tax. So that allowed that amount of money to come back into state revenues. About 22 million of the target, and then the other was this rate cut.
This is interesting. So the Hospital Association basically said, "All right, we'll agree." You didn't say you love it, but you said we will accept a rate cut if you create a new program that will let us earn bonuses, incentives if the quality improves. Why did you agree to cut your own rates?
Right. Well, people. We didn't, first of all. I mean, it was submitted as part of the budget, so it was like, okay, how do we make this more of a win-win?
Because you could fight with lobbyists at the State House.
We could, and we could, try to mitigate the cuts. We could try to eliminate the cuts, and we could do all of that. And that certainly was an option that was available to us. But what we tried to do instead was create this win-win where that we would rather see the value of those rate cuts go into an incentive pool. And if the hospitals meet quality metrics, which we'll be developing, they can actually earn those rate cuts back, and I'm hoping in their totality. So, and then the pool wouldn't be paid out until the next state fiscal year, so the savings would be there for the state during this fiscal year, and then the hospitals could earn back based on their performance. We're on a October to September fiscal year. So it wasn't, I've heard people describe me being enthusiastic about these rate cuts, so nothing could be further from the truth. It was really, how do we do this in a way that directionally starts to get us into the area of healthcare reform, meaningful reform, rather than just going continually back to the same well in terms of year after year. Rate cuts don't really do good for anyone in terms of what we're trying to do, reforming the payment system and the delivery system. Medicare has been doing this for years. This is not a new idea. They call it value-based purchasing. Medicare pays you, but then they take a piece right off the top, and then you get to earn it back if you meet quality metrics. So it's not a new concept at all. We're kind of really borrowing from something that's been working at the federal level for quite a few years. And part of our charge also was to modernize Medicaid, reinvent Medicaid, modernize Medicaid. Medicare has been doing these things. Commercial insurers have been doing these things. They're not new concepts, so we were just applying them in the same way to Medicaid to really try to get everyone on board with these cuts.
Only about a minute left with a big question, but I'm going to ask it. Right. One of the big ideas behind President Obama's health law, get more people insured, hospital groups would see savings on charity care. What's been the impact? Have you seen that at Care New England?
We've seen a lot more Medicaid care. We've seen our uncompensated care drop. We've seen our bad debt drop. That's been a very positive impact on the revenue side. But we've also seen people have that coverage, Ted, and they're coming in for services. There was this pent-up demand, behavioral health being a really good example, where a year ago we were seeing 145 patients per day at Butler. It grew to over 175 patients per day, some days over 200 patients per day. Wow. We're not busing them in. I mean, this is pent-up demand. They have the coverage. They're coming in to receive the care. So on the expense side, that's driving expenses. So these dollars don't drop to the bottom line. We still have to provide the care, so that the margins haven't improved that greatly in terms of the Affordable Care Act. Now maybe it's one-time pent-up demand effect. Maybe it'll be better next year in terms of on the delivery side. So that remains to be seen. But I think all in all, it's covered people that were uninsured, so I support it strongly.
All right, well, Dennis Keefe, that's all the time we have. We could have done 2 or 3 shows, but I really appreciate you coming in. We'll have to have you back. President and CEO of Care New England, Chairman of the Hospital Association of Rhode Island, and Co-Chair of Governor Raimondo's working group, Dennis Keefe. A lot more to talk about in healthcare, and we'll keep covering it in this show. Thank you for joining us. If you missed any of this episode, you can catch it all on WPRI.com. See you next week on Executive Suite.